Hello, everyone. Welcome to this symposium, which is sponsored by Gilead. Our topic is optimizing the treatment of fungal infections, spotlight on evolving epidemiology, and the current diagnostic landscape. My name is Ronen Ben-Ami. I'm head of the Infectious Diseases Department at the Tel Aviv Sourasky Medical Center in Tel Aviv, Israel.
Good afternoon. It's also my pleasure to welcome you to this symposium. My name is Paul Verwey, and I'm Professor of Clinical Mycology at the Radboud University Medical Center in Nijmegen in the Netherlands. So today we will be addressing three aspects related to invasive fungal infections, and in all three areas I think there are new insights and also new developments. So the first will address the epidemiology of invasive fungal infections, especially also the prioritization of fungal pathogens and bringing that together, the need for broad-spectrum antifungals and also early treatment. And in order to establish early treatment, you need an early diagnosis, and the second topic will focus on the diagnostic capabilities and also limitations in Europe, and also go into the need for early diagnosis in critically ill patients. And the third topic we will address is new approaches to drug delivery, and that will also address a case study looking how we can improve the delivery of drug to patients. So we have an outstanding faculty today. Three speakers will deliver presentations. So the first speaker is Dr. Ana Alastrue-Izquierdo. She is, of course, well known in the field of medical mycology, and she works at the Mycology Reference Laboratory in Spain. The second speaker will be Professor Katrien Leroux, who is also professor at the Leuven University Medical Center in Belgium, and is also one of the leading experts in the field of medical mycology. And the third speaker, also renowned researcher, Professor Russell Lewis, who is an expert on pharmacology and works in Bologna in Italy. So this is the agenda for the symposium. We have the three presentations by Anna, Katrien, and Russell, and after that, we will have a Q&A session with a panel discussion.
Okay, so a few housekeeping notes. Audience questions will be answered by the panel during the Q&A session. We very much encourage your active participation during the Q&A session, so please submit your questions via the ECMID 2023 app.
So hello, I'm Ana Alastrue-Izquierdo from the Mycology Reference Laboratory in Madrid, Spain, in the Instituto de Salud Carlos III, and I would like to guide you today about the evolving epidemiology of invasive fungal infections and how we've been prioritizing the fungal pathogens with this exercise that WHO have developed in the last years. So these are my disclosures. And I always would like to start with this slide that I think most of you have used it already, or at least have seen it, in which I just wanted to show for those of you that are not very familiar with fungal infections that we are talking about a very broad spectrum of diseases that goes from superficial infections that are not very serious, skin, nail, or hair infections, but are very frequent in the community, to or other very important and severe infections like invasive ones that are related with invasive with very high mortality. So there are not clear estimations, but there are rough numbers that have been calculated. They say that fungal infections kill more than 1.5 million people and affect over 1 billion people worldwide. So the epidemiology is have changed and is evolving frequently. And here I will start with Candida. You can see here how different studies in the slide on the left side. You can see how different studies have shown a decrease in the number of Candida albicans, which is the orange color. you can see that if you see different epidemiological studies in the same places, Candida albicans number are decreasing and other species are increasing their number as Candida glabrata or Candida parapsilosis. And why is that so important? Because as you can see on the right side, you can see that Candida albicans is usually susceptible to all antifungals, and secondary resistance is not a very big issue in Candida albicans. But for example, in Candida glabrata, there are usually high MICs to azoles, and also the same as Candida parapsilosis, which is also a very frequent pathogen. It could be the second and the third, the same as Candida glabrata, and they are usually intrinsically higher MICs to echinocandins. So these differences, decreasing the number of Candida albicans and increasing other Candida species that are appearing in fungal infections is important because of this change in the susceptibility pattern. And this is a very nice slide from a paper that I like very much, in which you can see what is the impact of prophylaxis. So this change has resulted over many years of using antifungals, and this use of antifungals can change completely the epidemiology. And you can see here that if you use antifungals for more than 7 days, if you use fluconazole, you will have a different epidemiology than if you don't have prophylaxis. And if you use captofungi, the epidemiology will be different. So that is influencing the epidemiology that you have. One important example of this change in epidemiology is Candida glabrata. The current name is MICOSIS glabrata, but everybody knows as Candida glabrata. And you can see here also the numbers of secondary resistance in Candida glabrata are increasing in several studies. And this is worrisome because of the rise of echinocandin resistance with the azole resistance. So you can see we get into multi-drug resistant organisms because, as we discussed before, they are usually so higher mixed to fluconazole and other azoles, and they have been several studies showing that they are developing secondary resistance to echinocandins, as we will see. So here are some examples. This again the same. So the same country doing different studies, and you can see that the percentage of resistance to echinocandins in Candida glabrata are increasing and reaching almost 10% in some cases. In one study that we published a few years ago, we demonstrated how this echinocandin resistance of Candida glabrata can be developed in the patient within less than a month treatment with an echinocandin. And here you can see each color is a different patient and each line is a different isolate. We had typed all these isolates, and we've seen that they are the same. In some cases, we identified the first susceptible isolate, and in less than a month, under the treatment with an echinocandin, and secondary resistant strain developed with mutation in FKS2. So resistant development under the use of an echinocandin has been demonstrated in several times already. Another important example of the change in epidemiology in these days is Candida auris. I think I don't need to explain you anything about that because so far we've all heard about Candida auris several times, but it's important for you to remember that the main problem is that the antifungal resistant patterns is quite unique, and it's also causing nosocomial outbreaks of very difficult control. And you can see here all the countries in which outbreaks were reported. CDC had a map in which they were updating the number of cases every second month or frequently, but now the map has not been updated anymore because the number of countries reporting Candida auris has been so big that it doesn't make any sense. This species was described a few years ago, and since then it has appeared in almost all the continents, and in all the continents causing very difficult to control outbreaks, especially in some countries. In Europe, it has been reported. In Spain, we still have an outbreak going in a region, and there are other countries like Italy and Greece in which, as we will see later, there are outbreaks ongoing now. As I said, it's important because the resistance is the first candida that pan-resistant isolates has been described. So it's usually resistant to fluconazole, and it shows also high MICs to other azoles. It has been up to 35% resistant to amphotericin B. Up to 40% can be classified as multi-drug resistant, and 4% of the strains have been described to be pan-resistant to all azoles or all antifungals described. And you can see here that the resistant patterns varies a bit depending on the clade. There are 4 or 5 clades up to now describe it, and these clades, as we'll say later, have a different pattern. Here is the last epidemiological update that has been released from Europe and has been led by ECDC. And you can see that the number of cases doubled from 2020 to 2021 in Europe, being some countries like Italy, Greece, places in which outbreak has been reported, and Spain been here highlighted because we have an endemic region in which we have been having cases in 2016, and although we have controlled a little bit that the number of cases is decreased, the outbreaks are still ongoing. And here you can see the very nice study coordinated by CDC in which several genomes were analyzed, and you can see that the colors, or maybe you cannot see it very well, but the different colors in the circle represent the resistant phenotypes. And you can see here that mainly all blue are resistant to azoles, and the other colors mean resistant to other antifungals. And you can see that it depends on the clade. The resistant pattern is different, but mainly there are pan-resistant isolates, and most of the isolates are resistant to at least one antifungal. Another example of the rising epidemiology of resistant species is Candida parapsilosis. We've actually having now a bigger problem with parapsilosis now in Spain than with other, with Oris or Candida glabrata, and I think it's the same in other European countries and also outside Europe. And you can see how the main mutation related to this Candida parapsilosis resistant isolates that are resistant to fluconazole. It has been related with the mutation Y132F in ERG11, which is the target for azoles. And you can see that the number of cases in which this has been reported and how it has increased during the last years. Here is a study that the people from our group here in the Mycology Reference Lab in Spain have investigated all the Candida parapsilosis strains that we received since 2000 to 2021. And you can see here how the MICs have shifted to the very resistant strains that you can see mostly in 2020 and 2021, where you can see both populations, but mainly resistant strains are rising. This resistant to fluconazole is in parallel to voriconazole resistant, but is still not resistant to all the azoles, at least in the mutation Y132F, which is the most frequent one. We have analyzed all these outbreaks thanks to all the hospitals sending us the strains, and we can see that there are different genotypes in different regions of Spain. So it's not only a single genotype, but different one. But in each hospital, one genotype is causing an outbreak, but are different from the genotype that is causing outbreaks in other regions of strains. And if you want to hear more, you can take a look at this nice paper that has been published a few months ago. So this was more or less about this, and now I would like to comment a little bit about molds. And the most frequent molds is, as you know, Aspergillus. Aspergillus, it can cause many spectrum of diseases, from invasive infections to allergies, and causing also chronic aspergillosis and some infections. So we have a very broad spectrum of diseases. While for many years we've seen that there is the most frequent pathogens have been Aspergillus flavus, Fumigatus, Niger, and Terius, we've seen, thanks to molecular identification and other taxonomical tools, that they are currently complex of a species. And this is also true in some of the yeast species and some of the Candida, but it's, from my point of view, very relevant in Aspergillus for what I will show you next. So here you can see one example, Aspergillus fumigatus, and is here on the left side of the screen, and is very, very similar to Aspergillus lentulus, which microscopically are very difficult to distinguish, and they can only be differentiated by molecular methods. Here we've investigated the prevalence of this species in different population studies, and it can be between 11 to 14%. And the importance of these cryptic species, especially in the group of Aspergillus fumigatus, is that they are per se resistant to some antifungals. So Aspergillus lentulus, for example, is intrinsically resistant to azoles and also amphotericin B. So this limits a lot our armamentarium to fight with this infection, and this has been related with the clinical outcome as well. But as you know, antifungal resistance in Aspergillus fumigatus is also a problem because of the development of secondary resistance. This has been demonstrated to be linked with the use of fungicides in agriculture, in which hotspots of high fungicides concentration are available, and then the resistant strains arise from that. So there are two mechanisms of resistance development in Aspergillus fumigatus. One is the one related to use of fungicides in agriculture, and the other one related to the prolonged use in these patients that we were discussing before, that can be chronic and can get azoles for months. So these two papers were the beginning of all these studies from the Netherlands and from the UK, in which you can see that the number of Aspergillus fumigatus resistant, secondary resistant to azole, arise. In Spain, we did a couple of studies, and one FILPOP one performed more than 10 years ago, in which we saw no resistance to Aspergillus, no secondary resistance in Aspergillus fumigatus. We repeated the FILPOP2 study some years later, published in 2018, and we reported it in 260 Aspergillus fumigatus. We found 1% of resistant isolates. 3 isolates were resistant to azoles, in which some of them we didn't know the mechanism of resistance. And the final study, the epidemiological study, the most recent one, is the one led by Dr. Guinea in Spain, in which he included all 30 centers and with almost 900 isolates. And in here you can see that resistant, second or azole resistant was present in 7.4% of the isolates. And as I was saying before, this resistance was not very high in Aspergillus fumigatus sensu stricto, although it's present, but it's almost all the strains of cryptic species are resistant to azole. So this resistance in Aspergillus fumigatus comes both from the secondary resistance of the Aspergillus fumigatus sensu stricto, and also from the cryptic species of Aspergillus, like Aspergillus lentulus, that you can see here. 10 of the cryptic species, 10 were cryptic species, and represent some of these resistant phenotypes. And this is just another our surveillance program, because we don't have very good denominators here. And you can see that most of our strains are also from Aspergillus fumigatus, and the cryptic species accounted for around 12% of the cases. So these are mostly all what I wanted to say about Aspergillus and how it is evolving the development of secondary resistance, or is the epidemiological change that we need to be more aware of, at least in European countries, because there are other places in which other species like Aspergillus flavus is the most frequent isolate, but in most of the world, Aspergillus fumigatus is the most frequent. And I would like to bring your attention to Mucorales. Mucorales are probably the second most frequent apart from Aspergillus, but the problem is that we don't really have a very good diagnostic method for this species. So mainly is based on culture and the culture, and as you know, the susceptibility is very low, and especially low in mucorales, because as you know, they are different from other molds. And here in this study that I won't guide you in detail through it, but I would recommend you to go and read it, because they have seen, they have screened a couple of cohorts of patients in which they have used PCR, real-time PCR, to diagnose mucormycetes, and they've seen, and they have diagnosed several cases only through PCR that were not culture positive. So it means that whenever we will have a better diagnostic marker or test, probably we will see more and more cases of mucormycosis. And this is a study that has been led by my dear colleague Carolina Garcia Vidal in Spain. And we've been doing the epidemiology of breakthrough infections in different hospitals in hematological patients in Spain. And you've seen here only the ones that are proven invasive fungal infections, all breakthrough infection. And you will see here that the 23 were Candida. Of them, 87% were non-albicans, and half of them were azole resistant. And 22% of them were mucorales. So mucorales are also very frequent in breakthrough infections. Overall, the resistant to azoles was around 50%. There is an increase in intrinsically resistant species. Mortality is around 50%, and when we're with echinocandins, the mortality rate up to 70%. Talking about mucorales and the epidemiology, I don't have time to go into detail, but there are many papers in which you can see the differences, because we are talking about the whole order of many genera. So here you can see that depending on the species or depending on the published study, you can see differences in the species that you are isolating. And while the Rhizopus is the main species found in most of the studies, you can see that, for example, in Africa, there has been, in this study of 18 cases, a high proportion were Lithemia, why for example in Australia, New Zealand, and Asia, and North and South America, for example, there is a number of cases of Apophysomesis that were not found in the studies of Europe and Africa. So this changes a little bit depending on the region. And also the epidemiology changes depending on the infection, the kind of infection that you have. For example, rhinoorbital infection is mainly Rhizopus or found, but if you are talking about cutaneous, it's more frequent that you find Saxenia or Apophysomesis or Mucor, while pulmonary infections are more Cunningamella. So these are also numbers that have to be adjusted, but I want to convey the message that mucorales, it's a broad spectrum of infections and a broad spectrum of species that can change, and the epidemiology varies a lot depending on different factors. And also here you can see depending on the part of the body, you will find different species of mucorales depending on the specimen. Another group of molds that I would like to discuss today is Fusarium, and Fusarium is important as well because they are usually resistant to azoles, and you can see here that there are many species. These are plant pathogens mainly, and there are many species. The taxonomy is very difficult, but the main species are the groups of Solani, Oxysporum, Verticilloides, and Proliferatum. And you can see that difference in susceptibility are not very high. We published a study in Spain, a retrospective study led by my colleague Elena Perez-Morales, and we studied the retrospective observational study in 18 centers in Spain, and we found that the number of cases has increased in these two periods, 2000 to 2009 and 2010 to 2015 here. The number of cases per 100 admissions you can see in this year. And the mortality in this group is 91.3% despite the antifungal treatment. So these are very complicated cases of whenever you are talking about invasive fusariosis. And I think the last group I would like to comment is Stereosporium lomentospora species, which are also have been described as emerging species. And you can see that there is also a complex of different species. It used to be Stereosporium apiospermum and Stereosporium prolificans, and now we've seen that Stereosporium apiospermum is a group of several species, including Stereosporium aurantiacum, ellipsoideum, boideum, etc. And Stereosporium prolificans is currently a different genera called Lomentospora prolificans that are in a different group, and they are highly resistant to antifungals as well. If you want to check the last recommended guidelines to treat these infections, there is a nice effort from ECMN in which there is a guideline for rare molds in which you can see which are important treatments for this infection. And in this study, you can see a very nice study from France in which they have done a multi-center retrospective study with cases of Stereosporium and Lomentospora, and you can see that most of them were Stereosporium apiospermum, but other species also exist. This was the part of epidemiology, and now I would like to guide you a little bit through how we did the prioritization of fungal pathogens for the development of the WHO fungal priority pathogen list. I have been very lucky to be able to coordinate the group of technical experts, international experts, that I will tell you a little bit how many people have contributed to this. But in October, it finally came up the result of a very nice document that I hope you all have read it already, but if not, please, I recommend you to read, in which we have categorized 3 groups of priority pathogens: the critical, high, and medium priority that you can see here. The process has been very complicated. It's a NCDA, DCA experiment, multi-criteria decision analysis. We did form the advisory group, the international advisory group from the fungal priority pathogen list. This initiative, of course, came from WHO, where they found some budget to do this. Then we draw the study protocol in which we select criteria to select all these pathogens. We did a pre-selection of the fungal pathogens that to be prioritized. They were firstly only decided by WHO, some of the more tricky ones, but then the experts added some of them. Then we did a selection of defined criteria to which we will rank these pathogens. We performed a series of systematic reviews in collaboration with the Sydney University and ANZIC study group from Australia, in which they performed systematic reviews of 19 pathogens that we previously selected. Then we ran a couple of surveys, international surveys, in what they participated over 100 experts, and in the other one 50 senior experts, and then we came up with NCDADC results in which each criteria was weighted and each pathogen was classified according to these criteria. Then we got a number, and we add the importance of the public health importance through a survey of some of the experts, and they define a final ranking. You can see here we did a couple of rankings. One is the research ranking and then the public health ranking, and we combined them at the end as is a result from the survey. So in the survey, we decided which ones were going to be. So it was 50% the research and development and 50% the public health. So just to finalize, because most of the methodology was presented last year in ECMID already, so what is new this year is what are the main takes-home messages, and these are the priorities areas for action. So one is in surveillance, and it's like we have to enhance reference lab to do surveillance of fungal pathogens, or to detect outbreaks, also to investigate a little bit more and try to develop burden of disease projects, also to enhance networks and development of collaboration. also enhance the stewardship and the appropriate use of antifungals, and also try to implement the WHO essential diagnostic list tests that are included there to try to make them available in all countries of the world. The second area in which we have to invest is the research and development. We need to invest in new rapid diagnostics, able to be able to deploy it in low and middle income countries, also improve the fungal identification and antifungal susceptibility testing, improve existing antifungals, develop innovative ones, enhance the clinical care health system, and also the partnership between public and private partnerships. And the third step would be the public health, in which we need to improve the global coordination for prevention and control, also enhance the education in all higher levels of education in healthcare workers on fungal infections, because as you know, it's not very well demanded lately. Also promote infection and prevention control both in healthcare but also in the community. Also ensure that the essential medicine list antifungals that are included there can be accessible throughout the world, and also use or prevent the use of antifungals rationalized in the One Health approach. So with this, I would like to conclude my presentation. I have a lot to say, but I hope I can convey to you the message which antifungal resistance is increasing, both in secondary resistance, for example, in Candida glabrata, Candida parapsilosis, or Aspergillus fulminatus, but also intrinsically resistant species as Candida auris or Aspergillus lentulus. And there's also emerging species as Mycorrhiza's, Sporium, or Fusarium that can be found and are also important. They are associated with higher mortality rates. So it's important to know your local epidemiology and also perform antifungal susceptibility testing as much as possible, but especially from any isolate that come from deep infection. And also monitor antifungal resistance. And for the prioritization of fungal priority pathogens, it was based on a multi-criteria decision analysis that, believe me, was very complicated. There were many gaps detected. Some of them, of course, are important because, as we know, there are no antifungal susceptibility testing methods available in many countries of the world, so it's very tricky to perform what I said in the other one. There is a known burden of disease. There are a lot of estimations, but we really need to get a better knowledge of the burden of disease. There are regional differences that has to be taken into account. And the antifungal resistance was a major determinant of importance in this prioritization exercise, but we have to take into account that despite having strains that are susceptible to all antifungals, mortality stays very high in fungal infections, and we detected the three areas of intervention that were surveillance, research and development, and public health. And I cannot thank enough the group of people that made possible that the fungal priority pathogen list was released, mainly all the people from WHO, Hatim Sati, that has coordinated the whole project, but also, of course, under the guidance of Hailey Getahome, and also Peter Beyer, Valeria Gigante, and Pilar García Bello. And also, and of course, the ADGM division, Professor Hannah Blanky, but also all my colleagues and the experts that have been giving all their hours, free time, for many of the days, from all over the regions and coming from different meetings, and also our colleagues from Sydney University that have performed most of the systematic reviews. With that, I would like to thank you for your attention.
During my presentation, I will discuss with you the European fungal diagnostic capabilities and limitations, and also why this matters for critically ill patients. So here you can see my disclosures. And I first want to start with saying that the prevalence of invasive fungal infections continues to increase. And this is because of different reasons. First of all, the population at risk is large and expanding. We do have the traditional hematological patient population, but also other populations at risk come up, like ICU patients and also the patients with advanced age. are increasing. And then we are also confronted with invasive infections due to strains with an intrinsic or acquired resistance. And then finally, because of the popularization of traveling to areas with endemic mycosis and climate change, we see also an increase in fungal infections. And because of that, specialized diagnostic tools are really necessary, as also mycological expertise. And last year, there was an ECMM survey of the European Confederation of Medical Mycology to see what the current status is of laboratory mycology in Europe. And for that, an online electronic case report form was being sent out to, as you see, nearly 390 institutions in 45 countries. And 64% of the participants were affiliated to a university hospital. So there is certainly some overrepresentation of university hospitals. And I think we should keep this in mind while seeing the results of this survey. Considering the availability of conventional diagnostic tests in European institutions, well, then it's clear that microscopy and specific cultural media to detect fungi are nearly universally present. But for the detection of fungi, we really need dedicated staining techniques and calco-fluor white staining. And as you see, this was only present in about 1 in 2 laboratories. Multitoph mass spectrometry is a very powerful technique for species identification, and this was present in 64% of the laboratories. And then considering antifungal susceptibility tests, there we see that about two-thirds of the laboratories are able to perform susceptibility of testing of both molds and yeast, but only in 1/3 of the laboratories, only testing for yeast is possible. So I think we can conclude that microscopy and culture are commonly available for the detection of fungal infections, but we all know that expertise is required for the interpretation. It's not only culturing the fungus, but you need to be able to identify them correctly and then also to interpret the culture result in the clinical context. So samples are generally processed in clinical microbiology labs and then can be sent to a reference lab if more expertise is wanted, but it is important that we also have expertise in these clinical microbiology labs. And for that, I think we cannot stress enough the importance of mycology training, mycology courses, to have this expertise available in all clinical diagnostic labs. And I just show you here some courses that are being organized in Europe. And just an example why being able to detect certain fungi is so important. I'm discussing with you the problem of Candida auris. As you might know, we do have in Europe now an increasing number of cases and outbreak due to this yeast. And at least in 5 countries, there were already outbreaks. And in 1 country, this yeast is already regional endemic present. And so this map here, you can see in light blue, these are the countries with only imported cases. So you see this is the case in few countries anymore, whereas for instance, Spain here you see is in dark green, and there it's really endemically present. So it is really important that we are able to recognize the presence of Candida auris in routine clinic samples to take also measures to prevent the transmission to other patients. And for this purpose, for instance, implementation of a Chrome agar for detection of Candida auris might be very important. And this is just an example how routine clinical labs also have an important task in the detection of certain fungi, like Candida auris. And then what about the availability of fungal biomarker tests in European institutions? Well, you see the highest bars are there for the Aspergillus galactomannan ELISA test. This is in nearly all laboratories present or provided either on-site or outsourced. We now see also that about 50% of the laboratories do offer a rapid Aspergillus antigen test, a lateral flow assay, which is also either performed on-site or outsourced. For the Cryptococcus antigen detection test, I must say I was a bit surprised to see that still so many laboratories use the latex agglutination test, because also here is a lateral flow assay available, which is more easy to perform and has an excellent sensitivity. The pneumocystis PCR is present or outsourced in about, let's say up to 80% of the laboratories, which is of course very important because this is really a crucial diagnostic test to diagnose pneumocystis infection. And then you see for the other fungal biomarkers, the PCR test to detect Aspergillus, Candida mycorrhizalis, or the beta-D-glucan test. Only a small proportion of the laboratories do offer this on site, and let's say a same proportion is also outsourcing this. As I said, there was an overrepresentation of university hospitals in this survey, and so we took the initiative to look in Belgium more on a national level what the implementation of lateral flow tests for the diagnosis of aspergillosis is nowadays. So we also sent a survey to all the Belgian laboratories and got a response back by about 70% of the laboratories. To give you an idea of the type of the hospitals that responded, nearly all had an ICU. About half of these centers did have or do have a hematology department, and some of them, let's say, do also perform organ transplantation. Well, we see in this context that only about 30% of the laboratories do perform the Aspergillus antigen ELISA in their setting, and very few laboratories, 11%, did implement up to now a lateral flow device test. Also, Aspergillus PCR is only performed in very few samples, and beta-D-glucan is all referred to one lab, the reference lab. So if you look at the evolution of the antigen detection test for invasive aspergillosis, well, it's clear that we have an important expansion. It's all started with the latex agglutination test to detect galactomannan in serum, and then soon after an ELISA test came to the market to detect this biomarker in serum. But then really it took some while before we were using this test to detect galactomannan in BEL, and we were then all waiting very much for other more rapid antigen detection tests where you don't need to batch your samples, but you can perform your test on a single sample. And so, as you see here, finally this test became available, first as a prototype, then finally as the OLM or the IMI test. But we see at the same time many other antigen detection tests for Aspergillus became available, ELISAs or other enzyme immunoassays, and most recently also an antigen to be detected in Europe test became available. So there is really an expansion of antigen detection assays for invasive aspergillosis, and now it is important to check the validation test for a specific test you consider to implement. And this is the case both for serum and BL, and also for the different patient populations you have in your hospital. So you have to keep in mind that validation data are still limited. I can say most of the data available currently are from the IMI lateral flow assay, which suggests really that the performance of this test is at least as good as for the Platelia galactomannan test, and therefore may even replace this test. I think in general lateral flow device tests are most useful when a rapid response is needed and when the number of samples in your lab is low. If we then focus a little bit more on the patients with invasive aspergillosis in an intensive care setting, then we see that the patient population at risk for this disease is really broad. As said, we do have our patients with hematology malignancies, but we have also many other patient groups at risk for this disease, such as COPD patients, but also patients on prolonged treatment with corticosteroids before admission to ICU. And most recently, we also discovered that patients with influenza and COVID-19 are at risk for this disease. And this really leads to several challenges. In this patient population, it is really difficult to make differentiation between colonization and infection. This is much more difficult than in the hematological patient population. These infections are really associated with a high mortality. The imaging findings are typically A-specific, and for that, because of all these reasons, we really rely very much on the results of biomarker tests to make the diagnosis, but we don't have the optimal biomarkers yet and not an optimal diagnostic algorithm yet. And now we're speaking about invasive aspergillosis, but of course these patients might also be at risk for other invasive fungal infections such as invasive candidiasis, pneumocystis jirovecii pneumonia, and mucormycosis. If you then look a little bit closer at invasive pulmonary aspergillosis following an influenza infection, then we see that there is really a high impact on outcome of our patients. As seen here in this table, there is a significant impact on the stay, the ICU mortality, hospital mortality, and also 90 days mortality of ICU. The high incidence is also a very important issue. In a prospective study, it was clear that invasive pulmonary aspergillosis in patients ending up in ICU with influenza has an incidence as high of 20 or 25%. And most of these infections are diagnosed within the first 2 days upon ICU admission. So we can speak more about a co-infection than a secondary infection in most of the patients. And this triggers the question, shouldn't we start empirical antifungal therapy and initiate also a diagnostic mycological workup within 24-48 hours with bronchoscopic evaluation? And of course, when the test then would return negative, then we could stop this empirical antifungal therapy. And also want to remember that the sensitivity of bowel culture in this setting for aspergillus is only 63%, so we certainly cannot rely on culture solely. And as we do rely so much on biomarker tests, it's important to know what is the performance of these biomarker tests specifically in this patient population. So we performed a retrospective autopsy-based study in adult ICU patients that were admitted either with influenza or COVID-19 and had respiratory insufficiency, and finally a fatal ICU stay with a post-mortem evaluation. So the autopsy rate was quite high, I think, 31% in severe COVID, 44% in severe influenza. So you can see here the total number of patients that were included. And so we finally ended up in patients with severe COVID-19 and severe influenza in both groups with 6 patients with proven aspergillosis. And of course, in this proven group, we can see very well what the performance is of the diagnostic test. And as already known from before, the sensitivity of bowel culture is quite limited, only about 60%. Looking at the serum galactomannan sensitivity, it's 33%. This is low. On the other hand, it means that 1 in 3% you really can detect galactomannan in serum. If you're looking at the bowel galactomannan test, then we saw that it had an excellent sensitivity, but that the specificity was poorer. This was in all patients that died and in whom the bowel galactomannan was being performed, irrespective of prior mold-active therapy. So it is possible that in some patients in whom the bowel galactomannan was positive and a prolonged treatment was given, that the fungal infection was eradicated at the time of autopsy. So if you restrict the analysis to the autopsy-verified negative group without prior mold-active antifungal therapy, then we see that the specificity of the bowel galactomannan is much higher. And I want to spend a little bit more time on invasive tracheobronchial aspergillosis, which is really a specific entity of invasive pulmonary aspergillosis, which entirely or predominantly involves the tracheobronchial tree. And so upon bronchoscopy, you can see these ulcerations, nodules, eschars, and pseudomembranes in the large airways. And so when you take a biopsy sample, then you will see that aspergillus will grow from these samples. And even in the bronchoalveolar lavage fluid, you can see really these aspergillus heads. And why do I want to stress a little bit on this specific entity? Because it's really a severe entity. And that we learn also from this retrospective observational study being conducted in ICUs, 3 ICUs in France. And so here, all patients that were admitted to ICU with respiratory failure and the diagnosis of influenza and invasive pulmonary aspergillosis were eligible. And these patients and all patients, of course, should be assessed by bronchoscopy. So in that specific patient population, nearly 30% of patients indeed did have this specific entity. And if you then have a more closer look at the biomarkers in this patient population, you see here the beta-D-glucan serum level, the galactomannan serum level. It's clear that these levels are higher in the patients with invasive tracheobronchial aspergillosis, and also the galactomannan in the bronchial alveolar lavage fluid was higher. And this all points to a higher fungal load. If we then look at the survival, we saw also that mortality in this patient group was really very, very high, 90%. So you can argue that this was maybe due to the fact that there was a delay in diagnosis, but this was not the case. Actually, according to the design of the study, all diagnostic assays were being performed upon admission to the ICU, and the delay between diagnosis and invasive pulmonary aspergillosis was even shorter in these patients with this specific tracheobronchial entity. So I think here it's clear that with our diagnostic approach and the therapy we are currently given, that we still have a very poor survival, and further studies are certainly needed to evaluate the benefit of combination antifungal therapy. And then I'm thinking also about combinations with inhaled antifungal therapy to get really high concentrations of the antifungal in the airways. So this was about influenza-associated pulmonary aspergillosis. Also in COVID-19 patients admitted to the ICU, we see pulmonary aspergillosis as a quite common complication in about 15% of patients. Here the delay is a bit later. It seems that this complication typically occurs in a window of about 3 to 9%, but both in COVID-associated or influenza-associated pulmonary aspergillosis, mortality is really high, around 50%. So the case definitions we are currently using for viral-associated pulmonary aspergillosis do have their limitations. If you see at the cornerstone of the EURTC MSG-ERC definition, there we see that this is a combination of host factors, clinical factors, and microbiological evidence. However, when we are dealing with viral-associated aspergillosis, the host factor, in fact, is the viral infection itself. And then the clinical factors, as said, this is mainly imaging, but imaging is very aspecific in an ICU setting. So we rely heavily on the microbiological evidence. And so with the current definitions, it's that a single positive fungal test in a bowel or serum is really sufficient to classify the patient as having a probable viral-associated pulmonary aspergillosis. And so this may certainly lead to an overdiagnosis of this infection. And we do not take in the current case definitions also the negative diagnostic test results, we do not take them into account. And when I just refer here to a retrospective observational study being conducted in the ICU of 2 university hospitals in Paris, where they included all successive patients hospitalized for COVID-19 who did require mechanical ventilation and who worsened clinically during a 1-year period, then we see that there is a clear correlation between the survival and the number of microbiological diagnostic criteria for aspergillosis that were positive. So now we are looking also together with our colleagues from Nijmegen if there is a new approach needed to classify patients with invasive mold disease and to see, for instance, if machine learning-based algorithms could be of help for invasive mold case classifications. And a high awareness to diagnose the COVID-associated pulmonary aspergillosis is important, and as such, I wanted to show you here this initiative, which is the result of a collaborative agreement between the CDC, the University of Alabama and Birmingham, the MICOSIS Study Group, Education and Research Consortium, and also Terra Nova Medica, because they developed an educational tool to help ICU clinicians to consider fungal infections when they are taking care for patients with COVID-19 receiving mechanical ventilation in the ICU, and then especially when the clinical course is deteriorating. And so they have this kind of checklist, the first checklist here presented in table 1, to see if clinical criteria are present that point to COVID-associated pulmonary aspergillosis, and then also another checklist to see which diagnostic criteria are present. But uncommon clinical presentations of fungal infections are really still challenging to diagnose. And I want to illustrate this with this case. It's actually 37-year-old male with a well-controlled inflammatory bowel disease under infliximab. And then at November 2021, he was diagnosed with a mixed phenotype acute leukemia and therefore got a remission induction and consolidation chemotherapy. And so some months later, in March 2022, this person was transplanted and actually had an haploidentical allo transplant. 69 days after transplantation, this person admitted to our hospital with symptoms compatible with acute lower intestinal GVHD, which was finally also proven histopathologically. And so if we look now, day 69, there was the hospital admission, and then because of these complaints and the diagnosis of GVHD, there was an increase of the dose of methylprednisolone, but despite this, there was a further deterioration with the painful cough, diarrhea, general weakness, also an increase in the inflammatory parameters. And because of that, antibiotics, cifepime, were started empirically. Also, 2 sets of blood culture yielded Enterococcus faecal and faecial, and because of that, vancomycin therapy was added. But there was a further gradual development of neutropenia. Fever persisted despite antibiotics. All cultures remained negative, and the chest CT also was negative. So on day 73, they decided to start ruxolitinib because of persistent GVHD. And then at day 75, an abdominal CT scan was being performed and showed small bowel dilatation with wall thickening, which also was suggestive of GVHD. The course was not well. On day 85, the patient had to be admitted to ICU. At that time, an abdominal CT was performed, and this revealed a thrombosis of the splenic artery with infarction of the spleen and the left adrenal gland, and there was also gastric ischemia. So also in ICU, the patient further deteriorated. On day 89, there was a multiple organ failure. So because of that, it was decided to do a complete source control with total gastrectomy and splenectomy. And upon operation, they also visualized ischemic areas of the small intestine and colon. And 2 days later, it was decided to perform an explorative laparotomy. And also there, as you see here clearly on the picture, there was necrosis of the entire small intestines. And then on day 92, the patient finally died. And so the tissue that was taken, the resected stomach, spleen, and omentum was being evaluated, and then we got the result back, and you can see it here on the picture. There are clear fungal elements present, and these fungal elements were suggestive for the presence of mucormycosis. So we did also this PCR on the resected tissue, and this PCR was positive. And then we started to look back at the stored blood samples that we had from this patient, and actually we found out that the first positive mucorales PCR was there at day 75. So if we would have performed this PCR on blood, we could have made the diagnosis much earlier. And so you here see the evolution. These are the CT cycles of the mucorales PCR. You see this first positive PCR here on day 76. And then further a lowering of the CT values, which means a higher fungal load. So this PCR can really be of value in the differential diagnosis of at-risk immunocompromised patients with bowel obstruction and or abdominal ischemia. And I just want to refer here to another study where the performance of serum PCR for mucorales was being evaluated. And to summarize, the excellency performance was very good. It turned out to be an early marker, a positive 4 days before mycological or histopathological examination. Also, in 1 in 3 patients, it seemed here that there was a co-infection, Aspergillus mucorales. So it's not because you detect an Aspergillus that mucorales could not be there. And it had also prognostic value, because when your PCR remains positive despite appropriate antifungal therapy, they saw that all patients finally died. Of course, this is a PCR test. An antigen detection test would also be very useful, because this is even a more rapid and easy to perform test. And I think there is some good news here. It seems that these tests are being developed, and I hope they will become available soon. And therefore, I want to conclude that the population at risk for invasive fungal infections in an ICU setting is expanding. And so a high awareness and combination of different diagnostic tests are really crucial for the diagnosis and early treatment of these infections, especially in an ICU setting. And I think I showed you that commercial fungal diagnostic tests are expanding, but validation data at this moment are still often limited. So also new fungal treatment strategies are warranted for the high-risk populations in the ICU setting, because mortality still is high. Thank you.
Hello, my name is Russell Lewis. I'm an associate professor of medicine and infectious diseases in the Department of Molecular Medicine at the University of Padua in Italy. It's my pleasure to have this opportunity to talk about the role of nanomedicines in drug delivery, and particularly an example of liposomal amphotericin B, because liposomal amphotericin B was introduced at the beginning of the nanomedicine era, I think, clinically in the late 1980s into the early 1990s. And since then, it's been 30 years, and there's been a lot of interest in developing nanomedicines and this technology, not only for infectious diseases, but also especially in oncology. So it's an interesting time to go back and look at what have we learned about nanomedicines from liposomal amphotericin B, and what's the potential for the future. Now, I have worked in the antifungal space for over 25 years, and so I have some relationships or worked with companies, and it's important that I disclose those before we go forward. So I think we should start by defining what we mean by nanotechnology or nanomedicine. Essentially, nanomedicine is a field of medicine that is looking at the manipulation and engineering of materials on a nanoscale level, which is typically between 1 to 100 nanometers in size. The reason that this is of interest is because typically we think about macro molecules, and at the macro level, where drugs have certain physiochemical characteristics, They may interact with membranes in a certain way, but when you actually go down to the nanoscale, these factors change. For example, the surface area, the volume changes of molecules, so they may be better absorbed, where they may be not bioavailable at the macro level. The surface reactivity of molecules changes, so they may interact in different ways with cell membranes and biological systems. And the stability and solubility of many compounds will change. So when you go to a nanoscale, you can potentially address many of the problems we face in clinical pharmacology in terms of bioavailability, targeting different tissue sites, and improving the stability of compounds. So we can understand why there's a lot of interest in this area, particularly in the oncology and the infectious diseases field, where we face a lot of challenges with making precision diagnosis and delivery of drug therapy to sites of infection and trying to distinguish what's the pathogen that we're dealing with. There's a lot of interest, of course, in can you develop precision therapy and targeted delivery strategies for drugs in the site of infection, and specifically targeting disease tissue without having off-targeted effects. And even there's interest in, can this be used as a technology to stratify specific disease biomarkers or even the genetics of the patient? So there's lots of talk about precision therapy and precision medicine. We infuse drugs into patients, or we give them an oral pill, and we just sort of allow the drug to go where it might based on its physiochemical characteristics. So nanomedicines represent another strategy for improving precision therapy and could have enormous benefits in the treatment of many infectious diseases. Of course, the other discussion is when you talk about nanomedicine, often what you arrive at is nanocarriers and ways of delivering drug therapy better. And we have an example of a first-generation nanocarrier with liposomal amphotericin B. Generally, first-generation nanocarriers are compounds where the primary role is to enclose the molecule or therapeutic agent inside a liposome or micellar lipid molecule, and then help the compound localize to the site of infection, and this can improve the therapeutic index. Second generations are molecules where nanocarriers are where you actually may make surface modifications. You may attach antibodies to try to improve the targeting or accumulation of drug at a site of infection or diseased tissue. And then there's even discussions of third generation nanocarriers where you may actually have staged interventions where there's sort of a stealth drug delivery vehicle. It arrives specifically in infected tissue, and depending on what's occurring in the tissue, it may release diagnostic agents, it may release the therapeutic agents, it may do this in combination, it may do it at different times. And obviously, with each generation, you're dealing with increasing complexity in terms of the nanocarriers. But there's been interest in developing an ever-expanding toolbox of improving these capabilities depending on what is the therapeutic problem you're facing. If the problem is simply drug delivery and improving therapeutic index, often liposomes and polymeric micelles are the most common approaches that are used. And this doesn't have to be drugs. This has included things like RNA and DNA and even diagnostic agents. But if the issue is, for example, drug stability, you may use nanocrystals, silica nanoparticles, polymer drug conjugates that can considerably improve the stability of the compound and may allow for different formulations. If you need to target immune cells, you could use protein-based nanoparticles to specifically target immune cells that may be involved in hematological malignancies. And there's this interesting new subset of nanoscale delivery approaches called dendrimers, which are essentially scaffolds that allow you to attach a wide range of either compounds or diagnostic agents, functional groups, antibodies. These can be manufactured in a highly customized size for the purpose at hand. So I think it's really quite incredible to think about what the potential is of the tools that have been developed over the last 30 years for engineering drug delivery and improving the specificity and safety. And this doesn't even just rely on what kind of particle that you develop, a nanoparticle delivery system. You can also make it responsive to the disease state, to the infection site. You can make this so it has a time release that either based on endogenous triggers in an acidic hypoxic environment, for example, that you might find an infection, or maybe exogenous triggers. There's actually nanoparticles where we can cause release in a specific site through the use of light, sound, or magnets. So a lot of this seems like science fiction, but the technology has been developed, has been proven in mostly animal models. And the question is then, are we going to see this come to patients? And I think the thing that's exciting for the fungal world is we already have a proof of principle that nanoparticle delivery formulations can considerably improve even older medications. And of course, that's liposomal amphotericin B. And we have two other formulations of amphotericin B that were developed. But liposomal amphotericin B is the one that stood the test of time and has the greatest amount of clinical experience. And the most important advance with the liposomal formulation was the ability to deliver amphotericin B with less nephrotoxicity compared to conventional deoxycholate formulation, which was shown in this study by Prentice and colleagues many years ago in the British Journal of Hematology. And it's hard to underemphasize how important this was, particularly in populations such as bone marrow transplant patients, where if they develop a fungal infection and they required amphotericin B deoxycholate, and they developed renal toxicity, this not only was associated with morbidity and mortality associated with the infection, but it also really derailed the transplant because effective management of the transplant, post-transplant graft versus host disease required us to use calcineurin inhibitors, other nephrotoxic drugs. And if you couldn't give these agents, it became very difficult to modulate the post-transplant course and ensure the patient remained in complete remission. So there's lots of other downstream effects of avoiding these toxicities and improving specificity. So that's a very successful example that we have. And we then can step back and think about what are the other potential biological barriers or clinical problems that we face with our current antifungal armamentarium. Right now, all of our antifungal pharmacology, the issues of spectrum of activity, toxicity, drug interactions, these are things that we can't decouple. If you have a triazole antifungal, then you're sort of, okay, you may have a formulation that can be absorbed, but it's going to cause drug interactions. You may have a triazole antifungal that has broad spectrum of activity, but it doesn't penetrate well into the central nervous system. So imagine if you could take an antifungal and then separate of the spectrum of activity, improve its bioavailability, which we have seen some attempts at doing that, but also improve its targeting of an anatomically privileged site, such as the central nervous system, or concentrating the drug inside of epithelial cells of the lung to make it a more effective prophylaxis agent, or concentrating it inside immune cells to make it effective for leishmaniasis. One of the holy grails we often talk about with mold disease is tissue invasion and necrosis. Can you have drugs that target hypoxic environments and damaged tissue? And biofilms, we know, are a major cause of resistance and recurrence of invasive fungal disease. Could we develop unique targeting strategies that better deliver antifungals deep into the biofilms to kill not only these quiescent fungi that can lead to relapse? So with the molecular tools that are being developed, I think that we see that there's some challenges that could maybe be addressed through this growing toolbox. Also, we know that there are many areas of the world where antifungals are underutilized, and these are often the areas where invasive fungal disease is very prominent and associated with very high morbidity and mortality. I think nanomedicines have a potential to broaden patient populations who are not candidates for traditional therapy. For example, not candidates for intravenous amphotericin B or liposomal amphotericin B. It is possible to develop using self-emulsifying formulations, bioavailable formulations of amphotericin B that could potentially be given in a capsule formulation. There's been a lot of work in using lipid nanocrystals or cochelate formulations. And it's always interesting in the antifungal sphere, when you look at the literature, people always focus on amphotericin B because this was classically the most problematic drug in terms of getting oral bioavailability and improving its therapeutic index. So I think it's a drug that lends itself very well to reformulation in nanoparticle formulations. And hence there continues to be, even after 40, 50 years, a lot of interest in developing new formulations of amphotericin B. But if you were to be a little bit more critical and step back, you would say, well, okay, liposomal amphotericin B, or Ambisome, was introduced in 1997. Where are the other nanomedicine-based formulations of antifungals? And even in the oncology space, where there is a lot more investment and a lot more money and research being developed into nanoparticle formulations for novel chemotherapy agents, there's been relatively few drugs that have advanced and come to market since the 2000s. Even in the last 5 or 10 years. So why are there still so few nanomedicines and nanomedicine formulations in clinically? This is also reflected, I think, in the literature. If you look at some of the titles just in the last 5 to 6 years, nanomedicine is the wave cresting. Cancer medicine, are we targeting our target? Is targeting our target? Maybe we need to rethink our whole approach to how we're trying to develop new nanomedicines for cancer. So many papers and so few drugs. And this is, I think, just a reflection, not necessarily not of the potential or the lack of potential of nanomedicines, but it's following a classic biomedical technology life cycle that in the early phases of a new technology, there's a lot of excitement. You have some pioneering breakthroughs like a new formulation, and the assumption is it's easier than it's very easy to do, and it's very easy to apply this to other therapeutic areas. And then you have a big funding wave, and this happened in the United States, for example. There was large-scale sequestered research funding put apart only for developing nanomedicines and trying to advance this field forward. There was a U.S. NCI Alliance in Nanotechnology and Cancer, developing centers of excellence. The National Health, Lung, and Blood Institute developed a program of excellence in nanotechnology, and they even developed 8 NIH-funded nanomedicine development centers. And yet, once again, where are all the new drugs? And since then, the NIH is no longer accepting targeted nano applications in nanomedicine. And now you have to compete through traditional NIH mechanisms, even though there are still targeted funding areas for the next big thing, microbiome, obviously global health, underdiagnosed diseases. And of course, when there's less money, players start leaving the field, and there becomes a reassessment of what are the challenges and the difficulties. And then there's sometimes a rebirth or reignition of the enthusiasts who know the technology and understand it and can find more pragmatic approaches and ways to advance it in clinical research and applications. And I think that's the era that we're entering into now. So even though we've gone through this big wave of funding and excitement and haven't seen new therapies for fungal infections, maybe in the future we're now reaching a improved understanding of what the challenges are and how this can be done in the future. But certainly you can look at parallels in oncology and see that there has been a lot of interest in developing second and third generation nanocarriers, and many of these efforts have really failed. The ones that are still effective are their first generation agents like liposomal amphotericin B. And of course, liposomal amphotericin B is been available clinically for 30 years and continues to play a very important role in the treatment of invasive fungal infections. So I think it's it's important to kind of go back and think about a little bit of the story of liposomal amphotericin B and what lessons it may teach us for the development of new formulations. If you're not aware, liposomal amphotericin B was sort of born out of the biotech industry in California. During the 1970s and 1980s, there was the scientific advance of liposomes, and the advanced manufacturing techniques began to be established where companies were being developed to generate or produce liposome-based therapeutics, primarily focusing on cancer therapeutics, oncology space. And a small company, Vestar in California at the time, was developing engineered small liposomes less than 100 nanometers for cancer therapeutics that featured a single bilayer membranes, a neutral net negative particle charge, and a lipid bilayer motif of choline and cholesterol in a 2-to-1 molar ratio. The important thing that Vestar was trying to do is develop stable liposomes that were not cleared by the liver, kidney, and macrophages rapidly, and had extended plasma lifetime and tissue distribution to improve the pharmacokinetics and therapeutic index of chemotherapy agents. And this very brilliant mycologist, Professor Jill Adler, along with Richard Profit, Jill was doing a residency at Vestar, and she immediately understood the potential of using this technology with antifungals. And particularly amphotericin B was a very ideal candidate to incorporate into liposomes because it inserted naturally into the bilayer, taking advantage of natural binding to cholesterol that was present in the liposome formulation. And this was how Ambisome was born. It was understood immediately that this would change the therapeutic index of amphotericin B, and this is seen, I think, most clearly in vitro assays that can actually be used to assess its specificity of drug release. One of the ways that we can do this is looking at potassium release by red blood cells, because when there's non-specific interactions or interactions with human cell membranes, this will damage the red blood cell and cause a release of potassium. And so if you measure this, you get a sense of if there is non-specific or undesired binding of the amphotericin B. So we see the differences with the 4 amphotericin B formulations at the time, the gray line representing deoxycholate or conventional amphotericin B, and within minutes of exposure, we see this massive release of potassium, suggesting damage of the cell membrane. With amphotericin B colloidal dispersion and amphotericin B lipid complex, 2 non-liposomal formulations that are less thermostable and release amphotericin B more rapidly, there was a slower release, but still a very high rates of release of potassium over time. And contrast this with liposomal amphotericin B, the yellow line, where the rates of potassium release are very low, out to 500 minutes after exposure. Okay, that's really suggests that the liposome is protecting the amphotericin B interaction with cholesterol on the cell membrane of red blood cells. But the second half of the story is the graph on the right, where we look at potassium release by Candida albicans, once again showing the same thing, but this time the interaction of amphotericin B with ergosterol and damaging fungal cell membranes, and there's no difference. These dose response curves of potassium release versus concentrations of amphotericin B are superimposable. So it shows there's no difference in therapeutic index in terms of fungal killing and damage to the fungal cell membrane, but a marked difference in the damage to the human cell membrane. And this was immediately reflected in clinical studies with liposomal amphotericin B, starting with a very problematic issue with amphotericin B, and that's infusion-related reactions. Because amphotericin B deoxycholate, we know, actually activates monocytic cells and macrophages by binding to toll-like receptor 2. This causes release of pro-inflammatory cytokines like TNF-alpha and IL-6, and gives the patients chills, rigors, and fever. And so we try to reduce this adverse effect by giving hydrocortisone and antipyretics, but it can be an unpleasant experience for the patient. And with Ambisome, liposomal amphotericin B, what we see is a diversion of the TLR2 signaling to TLR4, and the concentrations in the serum of IL-6 and TNF-alpha were much lower and associated with much lower rates of chills, rigors, and fever. So this was an immediate toxicity that was markedly reduced with the incorporation in the liposomal formulation. Now, I should point out, however, that you can see a separate type of infusion reaction with all nanoparticle formulations, including liposomal drugs. We see this with other biologicals, micellular drugs, radiocontrast media, and that is complement-activated related pseudoallergy, where through the activation of the alternative complement pathway, a nanoparticle can induce the release of biogenic amines, such as histamine, platelet activating factor, leukotrienes, And patients can experience an allergic-like reaction, such as bronchoconstriction. They can even have coronary vasoconstriction. And this is something that has to be a major a concern that we have to think about with any new nanoparticle formulation. But in particular, it's a much greater risk if the nanoparticle formulation is greater than 100 nanometers. So if you stay below this threshold, then generally the rates are going to be lower. But it just makes an important point that when we talk about liposomal formulations or nanoparticles or nano carriers, there are marked differences, and a lot of these differences we have to pay very careful attention to is the size of the particles, because this can play a role in the distribution of the drug and adverse effects. We also know that the size of the liposome changes tissue distribution, and what was learned in initially animal studies and some experience in clinical studies is that despite this change, and with this change in the formulation, we see the achievement of very high concentrations in the liver, spleen, and kidney, which are important sites of dissemination of fungal infection, while maintaining good concentrations in the lung and the myocardium. And even from animal studies, seeing that the penetration of amphotericin B seems to be improved in the cerebral cortex compared to conventional amphotericin B deoxycholate. So this was a benefit of improving concentrations in many target sites of fungal infection dissemination while reducing infusion-related reactions and nephrotoxicity. And this probably is reflected then in the overall experience that I'm just summarizing with this single figure here. This shows if you look at all-cause mortality risk compared to conventional amphotericin B, that the liposomal formulation of amphotericin B was associated with much lower mortality risk compared to patients receiving amphotericin B deoxycholate. And this includes not only liposomal amphotericin B, but also some other lipid products. And I think the key message here is if you can improve the therapeutic index, even if most of it is related to toxicity, then this can have substantial benefits in terms of clinical efficacy, especially in the most vulnerable patient populations. I remember when liposomal amphotericin B was introduced, there was a lot of discussion of when is the amphotericin B released. And there was an assumption at the time that, well, when we talk about fungal cell walls, they're like a plate of armor, and there's no way a liposome will pass through a fungal cell wall, and so it must just be released outside the cell wall. And there was some discussion then of how do we know then there's going to be the drug is actually going to reach the site of infection if the liposome doesn't release the drug right away. But some very interesting pioneering studies, I think, in terms of not only understanding liposomal amphotericin B, but also fungal cell biology of the cell wall, was performed by Louise Walker and Neil Gau's group, showing that actually the intact liposomes can penetrate through the cell wall of Candida albicans and reach the cell membrane before they disintegrate and released amphotericin B at the site of infection. So I think this is a degree of targeting that wasn't anticipated until, really in the last 5-6 years. And we continue to learn about how these drugs behave and perform in vivo in treating the infections, even though liposomal amphotericin B has been available for over 30 years. The other thing that we've learned a lot about, I think, is the nephrotoxicity of why liposomal amphotericin B has reduced nephrotoxicity. The general assumption is, well, the liposomes are not accumulating in the kidney. You could look at kidney tissue concentration and see the amphotericin B concentrations are lower. So the assumption was this was the reason. But there's even more specific mechanisms, because the liposome at 100 nanometers or between 60 to 100 nanometers or a little bit less is not going to undergo glomerular filtration. So it's not going to concentrate, reach the proximal and distal tubules in high concentrations like conventional amphotericin B deoxycholate. But also when you encapsulate amphotericin B in a liposome, this changes its interaction with lipoproteins. There's not as great of interaction with low density lipoproteins. It's shifted more towards high density lipoproteins. And we know in the proximal and distal tubules, there are low density lipoprotein receptors that play an important role in recycling of low-density lipoproteins and modulating our lipid levels. And so this is sort of a delivery point, a drop-off point for amphotericin B in the distal tubules. And of course, when you're reaching high concentrations, then the drug can interact with cholesterol in the membranes and cause the damage to the distal tubules, resulting in electrolyte loss and the activation of the tubular glomerular feedback mechanisms that result in the decrease in the glomerular filtration rate. And so when you incorporate amphotericin B into a liposome, you're avoiding this delivery to the LDL receptors in the proximal and distal tubules, and you're avoiding tubular glomerular filtration. And I think this explains why we see much less nephrotoxicity. And it also, interestingly, we've known for a long time that pediatric patients have lower rates of nephrotoxicity with conventional amphotericin B, and it probably has to do with the handling of lipid levels. It still achieved high concentrations in target site of fungal infections, and actually achieved higher concentrations in places such as the central nervous system, which is an important site of dissemination for fungal infections, and maintained or had lower concentration or accumulation in the kidney. Obviously, one downside is if you're not achieving concentrations in the urine, it wouldn't be an effective agent for candidiuria, for example, although this is not something that we treat quite as aggressively. So I think that we were very fortunate that this formulation met a lot of the challenges that we were facing with amphotericin B. Obviously, though, there's an interest in, can you develop different versions of liposomal amphotericin B? Can you develop also generic formulations of liposomal amphotericin B? And while it's certainly possible and the technology has existed for 30 years, I think once again, we have to be very careful and look just beyond simple pharmacokinetic measures and look at what exactly are the nanocarriers doing, what are their size, because this can lead to pretty substantial differences in the selectivity, collateral toxicity, potential for nephrotoxicity, and maybe even clinical efficacy. And this is shown by animal data comparing liposomal amphotericin B or Ambisome to another formulation called Amphigen, or Ambisome versus Lambin. And notice that the diameter, the median diameter of liposomes is different for these different formulations. Our red blood cell toxicity, potassium release, the K50, differs for Ambisome versus Amphigen. There were differences seen in markers of nephrotoxicity in terms of the blood urea nitrogen and renal tubular necrosis in animal models. And even survival rates differed by 30% between Ambisome and Amphigen in an Aspergillus fumigatus challenge model, and 60 versus 30% for Ambisome versus Lambin. So yes, you can develop different liposome formulations, but if they're not the same characteristics in terms of the diameter, the makeup, then you have to look beyond pharmacokinetics. You have to look at markers of safety, efficacy, and toxicity to ensure that they could be equivalent. So I think that the take-home message is that although there's all these technologies and all these variations that we can see with nanoparticle formulations, though what has been effective at this point in this field is improving on-target drug localization and reducing off-target toxicity. And this is true not only with liposomal amphotericin B, but also with the most successful chemotherapy agents. We have a pegylated liposomal doxorubicin. And if you're not familiar with this drug, the main problem is cardiotoxicity and patients developing cardiomyopathy, and it's the dose-limiting toxicity. So by developing a pegylated formulation, it reduced drug accumulation in the heart, allowed you to use the drug in higher doses in combination with other chemotherapy agents, so improving complete remission rates. Also, interestingly, less hair loss, which we don't think of as a serious toxicity, but it's very important for patients. And another example is albumin paclitaxel, a combination a new formulation that reduced infusion times, reduced the need for corticosteroids because of infusions. And so it has actually made the drug much more tolerable for patients, even though it didn't show improved complete remission rates. And I think this is a path where we can still see a lot of wins and a lot of improvements in our current antifungals, where toxicity and drug interactions continue to be a problem. So there is clear precedent for clinical benefit with nanomedicine formulations that we can address issues with the off-site target toxicity through pharmacokinetic modulation. We can possibly improve bioavailability. There's some evidence of that, obviously, with the triazoles. But then the question is, what will be the future? Are there ways that we can maybe target infected tissue in the future? Can we improve drug delivery at the site of infection and efficacy? And this is an area that's been explored more in oncology space, and they've had much greater problems because it's not clear that all patients benefit to the same degree from this type of targeting. And in fact, in most cases, this targeting hasn't been shown to dramatically improve the therapeutic benefit in the oncology space. And that's why there's been these articles questioning where the field is going. And it's probably because you need advanced biomarkers and better understanding of who's going to benefit the most from a targeted therapy. You probably need improvements in diagnostic imaging. So obviously, there's very clear parallels here with fungal disease. And most nanomedicines to date have been tested in broad populations, and the heterogeneity of biological barriers and infection and disease could mask the potential success in smaller subgroups. So these are big challenges that are facing, I think, the future development of new nanomedicine formulations. But clearly, there's still the potential benefit and promise for improving precision medicine for not only oncology, but also invasive fungal disease, as these two problems go hand in hand. And I think that we are going to continue to see this approach applied to improve the effectiveness of existing antifungal therapies. Thank you.
Okay, so on behalf of my co-chair, Professor Verwey, and myself, I would like to thank you, thank our three speakers for their outstanding presentations, and all of you for your lively participation, which made this such an instructive experience. I wish you all a great ECMID.